hello everyone. This is Dr. Valenti. I am very happy to receive my colleague and friend Philippe Collin, who will do shoulder arthroplasty, reverse arthroplasty. And the particularity is that he uses mixed reality, and he will explain how he will do. So I would like to thank a lot Wright and Isabel, Vanessa, and Maya, who support us on the difficulties to organize that. And I would like to thank Vims, because the Vims will do a very good recording with a very nice camera and a very nice picture. And I would like to present the case now. You know that they prepare the patient. The patient is a woman. I show you. This is the clinical case. Can you? This is a woman, right dominant injury, 82 years old. She's a small woman, 155 centimeters and 55 kilo. And the main complaint is a painful shoulder with a loss of range of motion. Forward elevation is 80 degrees. External rotation is 30 degrees. External rotation in abduction is 60 degrees. Internal rotation is 60 degrees. And you see that it's painful. On visual analytic scale is 3/10. The constant score is 30. And the value of the shoulder function is 50. The X-rays, standard X-rays, you see that there is arthritis on the glenohumeral joint, arthritis between the head and the acromion. This is AMADA 4B in the classifications. And more important is the quality of the calf. And you see that there is an atrophy of the supraspinatus, infraspinatus. Subscapularis is in continuity, but with a fatty infiltration type 2. External rotation is infraspinatus and the teres minor are efficient, but with a little atrophy on fatty infiltration type 1 or 2. So if you want to summarize, this is arthritis with no functional cuff, and we decided, because she is 82 years old, to do a reverse arthroplasty. We did the planification with eOrtho. It's very interesting because Philippe did the planification with IMASCAP, and you will find that the results are similar in the planification. And the native version was 0 degree, and the native superior inclination was 12 degrees. You understand that you have to do a superior bone graft or metallic as you want to correct the superior tilt to obtain a neutral or inferior tilt. This is a small patient, and many times we prefer to use a 36. I will give the opportunity for Philippe to explain how he did planification with the mixed reality on special glasses.
Annulé. Philippe, it's okay?
It's you now.
Thank you so much. So first of all, thank you everybody. I'm really sincerely very happy to be there. I know Philippe for now more than 30 years. We should not say that. And I'm very happy to be here with you to share that. Philippe is a perfect example of surgeon who like to share. And I'm so happy to be there today. Of course, I would like to introduce not the team here. I would like to thank them. Charles, who will assist me today, is from Wright, striker now. And Alexandre is my regular scrub brother in the daily life. And thank you, Alex. So do you see the planification here?
Yes.
So that's what we call head-up display. This is the principle of this technology. Of course, I cannot continue without thanking Maya and Isabel. I'm sorry for that. So this is the device, and you see it's a head-up display. It means that I will operate here, like that, and each time that I want to assess and to check something, I have everything here. Here, I can see the anatomy here, as you can see, and I can take it, I can do this, I can look at the posterior subluxation, I can look at the arthritis. You see, it's very easy to do everything like that. Then you can have here all the CT scan. If you have any problem, you can check on your CT scan here on all the slide. And here I have my planification. Of course we can. If you want to, you can do this. I need to have it here. For me, it's perfect.
Voilà, là on a plus.
It's okay for you? So you see the anatomy? You can take it's very easy.
Tu peux retirer la
you need
lumière
not
là.
more than you need, of course, you need to have an habit for that, but you can have during you can take the glasses and work with it during 1 or 2 1 hour. It's enough in order to have the habit to take it like this, to take here like this, and you can modify everything just with your 2 fingers like this. Now we can, if you go on the humerus side, here you can see, I can see everything. I can see the level of my cut that I want to have here. So this is the level of my cut, and here all the device that I've planned. Same on the glenoid side here. This is my entry point. You know that it's very, very important to have the entry point here. And here the joint. And you can assess range of motion. You see that I will see, this is the goal. This is what I want to have at the end. So let's turn to the anatomy. Is there any question? I can show something, or we can start to go directly on the patient now.
No, thank you, Philippe. It's a very nice demonstration regarding the possibility to explain on the glenoid side, on the humeral side. I think that this is for you. What is the main advantage is for people who follow you to follow your preoperative planification is for education for you, no?
Of course, it's very important for education because for 2 reasons. First, with this device, with the HoloLens, you can perform live surgery when you want. You just need to give the link to your friend.
Okay.
And the other thing is that you can have what we call remote assist. It means that if one of your fellow is coming back to your own country and is not very comfortable, he puts the glasses and you can help him during surgery. It's very, very, very interesting. This is a very interesting things for that.
Yes, I think that the last point is very important now. So you can start maybe, no?
Okay. You need to make a checklist or it's okay?
Checklist is okay.
Checklist is okay. So
it's the right side.
I can start?
He's a good patient. You can start.
Okay. I can start?
Yes.
Okay. Incision. So it's a deltopectoral approach, regular one, nothing special. La petite, là-bas. Non, prenez les deux. Do you have a step or something like that for Charles?
Oui. Alors, où est-ce que je réponds là? Et si je veux répondre à lui, si, il faut faire Hervé, je crois.
If the image is not perfect, just tell me. We have time to modify it.
On voit pas bien là, ça saccade. Tout à l'heure c'était comme ça déjà. Essayez de voir ce qui se passe. Tu vois, it's very choppy. Tu vois, ça va pas le retransmission là. Qu'est-ce qui se passe ça? Faut appeler Rudy là, c'est pas bon. Sinon on fait avec les lunettes là, vous passez aux lunettes. Oui, c'est Internet qui va pas. Rudy, putain. Ouais, appelle Rudy. Rudy, il était. C'est parce que le cerveau. Ah, tu vois, c'est variable.
Alors, on passe sur le lens. Alors, si on passe sur le lens, le problème, c'est qu'il faut pas. Ouais, non, mais ça ici, puis il faut couper faut couper. Enfin, si on a en plus un retour, on perd vachement. Donc personne ne verra ce que je fais en fait. Ah ben on y va. Moi, on fait comme vous voulez. Moi, je m'en fiche. Là, je suis bien. J'ai l'impression d'être chez moi. Tout va bien. Allez, Vicril, hein. Ok. Je vais me taper un mal de coups d'enfer, mais ça va. So we are going to go. I think it's better, in fact, because we wanted to make for you a perfect live surgery. We thought that it would be better to have this camera. So we are going now to go 100% on the HoloLens. So the only thing is I just to modify a bit the position of the HoloLens on my head. If not, I need to operate with the head like this. So just a couple of seconds, I'm going to do it. Okay? C'est fort. Annulé. So now we are going to be exactly with the HoloLens. It means that I should not move too much. If you have to use it at home, annulé. Annulé. Then you need to modify a bit everything in order to not have too much light into here. So what you need to do as well is to try to not move too much your head. So I'm sorry. See, if I move a bit, it means that I just try to not move, but I will sometime probably move a bit. I'm sorry for that. So I don't know if you see this. I've just cut here 1 centimeter on the pec minor, pec major, sorry. And I put a thread now in order to not forget to close it at the end. So the second step, tenez ça comme ça, Alex, ciseaux. The second step, which is very important, I think, it's to release very well here the subdeltoid bursa. As you can see here, you need to release that very well, like this. And it's exactly as Philippe, the presentation of Philippe. We have some a curved tear here, and you need to very well release this, like this. And I'm sorry, the only step where I put my finger in order to be absolutely sure that I release everything. There is a slight coagulation here. Écarteur, s'il vous plaît. Okay. So you need to put this kind of retractor, which is very, very good. You put it here, like this, and then you put your arm in external rotation, and your goal is to look for the 3 sisters now. Here, you can do this, and if you put your retractor here, they are very loyal, they are very faithful. You can always find here, look at her. There are 3 sisters here. Alors, Vicrylin. Okay, here, you can see here, the 3 sisters. C'est bon, mais et ça retransmet ou pas?
Oui, ça retransmet, ça lag un peu.
Ok. So you need to ligate the 3 sisters here. You put 1 thread here, another one here, another one here, and oops. Ce truc focus, il vient dans le champ alors qu'on lui demande rien du tout. Annulé. Then, the second step is to put 2 threads here in the subscapularis. It will help us to find very well the plan between subscapularis and capsule. So this is an important step. So you put 1 thread here. The quality is poor, very thin, but I think we will try to reattach it. I think that even if it's not very good, we take 0 risk to reattach it. We've made a publication and we showed that you don't limit external rotation when you reattach the subscapularis. So, of course, the rate of healing is very low, but I think it's worthwhile to do it. I cut tendon to tendon. I will show you.
Okay.
Okay, Omar. Do you have a good visualization here?
Perfect. You see the quality of the of the picture is perfect.
So just because sometimes I don't remember to put my head very low, so just remind it to me. Okay. Okay. You see that there is some lesion here. The subcap is very, very thin.
Yes.
So I'm going to open the rotator interval here. I think it's here. like this. And I'm going to open the subscap here. And you see it's very useful to put your thread in the Three Sisters because it gives you the level, the inferior part. So I need to open my subscap up to this level. That's very mandatory. Up to the lat dorsi here. So you can take, at this step, you take the Oman retractor from the superior part to the inferior part here, and you can continue to open your subscap up to, if this is the lat dorsi here, so you need to open it up to the lat dorsi insertion. You make some external rotation, you stay very, very close to the bone, like this. Like this. At this step, you should not dislocate. You put your your Fukuda, retractor. And you do it like that. You put your retractor here, and you ask your assistant to pull on the subscap like this. So I would like to spend some time here with you. Donnez-moi une pince plus forte, s'il vous plaît. Oops. In order to show you this trick, if you have younger surgeon online, this step is very, very important if you want to have a nice glenoid exposure. So what you need to do here, you need to release this under the coracoid, like this. Sometimes you have an artery here, and it bleeds. So don't worry, it's very, very frequent. And the goal, you need to prepare this as well. Mettez une petite griffe, s'il vous plaît. So you need to open it here. Okay, la griffe. And then, I don't know if you see very well here, you put your retractor here, and you need to find the plan here. This is very important. It's here. This is a capsule. Bistouri lame froide.
Vous voyez bien, vous?
You see it? And then here, you perform a capsulectomy, as you can see here. This is very, very important.
Non, mais regardez.
And then you remove all the capsule.
Qu'est-ce que vous faites là? Pourquoi vous changez là?
On voit plus rien? Mais on est avec quelle caméra maintenant? Et le HoloLens ou la mienne? Ou la tienne? C'est les lunettes? Okay, Batman? Oui, Batman. So at this step, you put a Batman retractor here. As you can see here, you see very well. And here, you see that you need to finish your release here, like this. This is the key point. You need to spend some time here. If you want to have a nice glenoid exposure, you will see later at the other step that most of the time we have a very, very good, we have a correct, you see, you need to finish here. You stay very close to the bone. You finish your inferior capsulotomy. Okay? At this step now, you are allowed to dislocate. Tiens, retire ça. Retire ça. On retire ça aussi. On retire ça aussi. Voilà. Normally, it's not difficult to dislocate. You take your Oman retractor here. You put it here. Fais la tarte, s'il vous plaît. Merci. You put one Oman here, one Oman here. And the last Oman, please. And the third one here. So you can see that the indication of Philippe was perfect. There is no other option for this patient than a reverse shoulder arthroplasty. You see that you can see perfectly the posterior cuff, which is bad one. You can see here the subscapularis, which is very thin, but not detached. And you can see here the arthritis of the head. Is it okay? I think that the infraspinatus is good and the teres minor is good. Look.
Perfect,
You
perfect.
can see it?
Perfect. So she has a good external rotation.
Yes, just good. Yes. So now we can switch to HoloLens. Of course, I'm sorry, I'm going to modify it a bit. So let's turn to why you are here today. So you go to humerus, you start clone view. You see here, you need to ask for a clone view. And then I will have here. You can see it? So normally it's here. Normally I can tweak it, but OK, c'est bon. So est-ce que vous voyez my hologram here? So I can take my hologram, move it as I want, and I'm going to put it as close as possible of my bone here. And you can see it's a perfect visualization. And I block it, and now it will not move anymore. Okay? So at this step now, for the HoloLens with Striker, we have visualization. Of course, we don't have yet the guidance. It will come soonly, but at the moment, that's what we can do. But you see, it's very good because I can compare my hologram to my bone, as you can see here. So, OK, lancidaire, s'il vous plaît. So, of course, we have decided to make a bio-RSA today. So I'm going to take the graft. OK. So you put your K-wire here, I'm sorry. K-wire here. This K-wire, the first step is to take the bone. Elle n'est pas tout à fait la même. So it's not exactly the same device that at home. That's why Alexandre was a bit bothered, but it's perfect, Alexandre. Don't worry. OK. So now we're going to take the graft. Maillet. OK, d'accord. So I'm just taking the graft now. OK, this is my graft. I will use it later. So now you remember your HoloLens, your hologram is here. My head is here. So I'm going to make my cut. I just check. And, OK, tenez. Je vais la reprendre tout de suite. Une pince, s'il vous plaît. OK. So I'm going to cut now right here. So here. Okay. So the cut is done. So now we're going to calibrate the ear diaphysis like this. We're going to be very soft, very gentle, because it's an old lady. Okay. Ouais, non, c'est bon. C'est bon. On commence en 1. So you remember that my humerus is here. If I want to modify it.
1B, 20 degrés droite.
Oops. I can check this. What is interesting, you see, I can if I want to modify to have the cut now, I can have my cut here. You see? I can compare. And you see the small part of bone here, the small part of bone here. I'm perfect. Okay, we continue.
1B, 20 degrés droite.
Ok, thank you Alex. Maillet, on a toujours besoin de ça du coup, mais faire attention, elle est plus stérile. Vas-y, continue Charles, parce que tant qu'à faire. Ouais, mais si c'est pas stérile, faut pas la garder. Ok, here. I would like to teach that to you. It's a reverse shoulder arthroplasty, and you can decide your retroversion. Here, you see my hand. This is 20 degrees of retroversion, as you can see here. So you can do this. Perhaps not really more. The second one. As you can see, HoloLens. The second one. Okay. It will be enough, I think, because I can hear that I don't want to break the humerus on this old lady. That's perfect. That's good. Perhaps a bit more. Okay. So yes, we're going to rim a bit just to show to everybody that you can do that. If your retroversion is not perfect, you can have you have a rimmer here, and you can adapt everything. Now we are going to protect this. I don't need this anymore. Tack. Oops. Okay. So now we're going to protect it like this. And the second stage, now we're going to go on the glenoid side. Here. Take the arm like this, Charles, please. The swab. La compresse, Alex, s'il vous plaît. So I take this swab. I put it just here in order to protect my deltoid like this. That's very important because the functional prognosis of this prosthesis is based on the deltoid. So you need to protect it. And what I would like to share that for you, for the fellow and everybody. The key point of the glenoidal exposure is the retractor. You need a straight one like this, okay? So you need to put it here and put the head not inferiorly, but put the head posteriorly like this. L'autre Batman, s'il vous plaît. L'autre Batman. Then you put the other one here. And what you need to do at this stage, it's to finish the superior visualization, sorry. So here it's a bit too high. I'm going to be a bit more inferior, like this. Okay, normally you should be able to see your biceps. And this is a bicep, so it means that I'm good. I'm happy when I see that. And you can finish here to open the superior capsule, and you can remove this. This is an important step if you want to have a very good, correct glenoid exposure, which is very important in terms of result for the total shoulder arthroplasty. Ok, le grand, the last one, please. Qu'est-ce qui s'est passé? Oui, il a bougé. Ok, ok. Ok. Alors, dans ces cas-là, il faut remettre tout du début, c'est pas grave. Take this. Take this. Si vous mettez la caméra, faites attention, faites-lui faire un demi-tour au truc là. Ça m'est déjà arrivé. Non, non, ça là, parce que sinon on a une image à 90 degrés. Voilà. Non, c'est pas ça, mais c'est là-dedans que ça se passe. Voilà. Okay, now, so you need to put your posterior retractor here, like this, and the anterior one here, like this, and the superior one here, like this. So normally, at this step, you have a correct glenoid exposure, as you can see here. Est-ce qu'on peut monter un petit peu la table, s'il vous plaît? Okay. So do you see the glenoid here? Alex, la gauche, s'il vous plaît. Non, non, pas de problème, pas de problème. Perhaps you can have a better light. Okay. It's not too much for you?
On règle la.
Je sais pas comment on règle ça, moi. Ok. Is it okay? We have time, huh? It's only we've started 30 minutes ago, so it's correct. Okay. You think that my exposure is not good? Voilà, qu'est-ce que c'est que ça? Oh, c'est pas mal là, non? Ça vous va là? Vous voyez bien la glène? OK? We see very well the inclination. Huh? We see that we need to compensate superiorly here. Okay, so now, second step, glenoid. This is, so same. You ask for clone view. I can wait?
Nous, on voit très bien votre retour, c'est parfait, mais eux, apparemment pas. Leur connexion n'est pas terrible, apparemment.
Hein?
Mais vous, la retransmission, elle est top. L'image est trop belle, là. C'est vrai.
Elle est trop belle, mais elle est que pour nous, quoi.
Ouais, elle est que...
C'est bon? OK, super. Donc là, regardez, on était en anatomique. I just remind to you. Now we've done humerus side. It's done. Now we're going on the glenoid side. This is what I've prepared, my entry point. You see that I should be a bit inferior, relatively at the middle. So I can start the clone view. And my clone view is here. And I can take it like this. And I will try to put it at the base place in order to reproduce here my entry point. Can you see? Here. In the near future, we'll have a calibration here, but at the moment, it's not guidance, it's only visualization. So it's like this, and you can lock it here like this. So you will have always the entry point that I've prepared and the glenoid here. Okay? So, point carré? Well, curate. So I'm going to prepare a bit. La gauche. Okay. It's okay here? Okay, la pointe carrée. Like this. You see here? Here? So that I want to reproduce this here. Like this.
Question, Philippe.
Yes?
You reproduce, but you know the distance between inferior and the center point?
Here? No.
Ooh. Where?
You
Where
have
is the distance?
you have no distance. You just have the visualization of this and this.
Yes, but you can put the entry point 2 millimeters up or 2 millimeters
Yes, it
down.
is not guidance, I agree.
Okay. How to measure, for example, the inferior tilt of your Kirchner wire?
At the moment, we cannot. So I would like to share this trick with you. I like to do that. You know, I lock to the door. And then it means that if you do that, I know that I'm at the right point because I have all this in the native glenoid. Okay? Peut-être un tout petit peu haut.
Tu peux faire ça, faire ça.
Là, je suis peut-être un tout petit poil haut. Ouais. I think I'm a bit too high. You see here? You see here, very interesting. You see here that should be there. There is an osteophyte here. I can find the osteophyte here. And I think I should be 2 millimeters higher. And I think I'm a bit off. Perhaps 1 millimeter too high. OK. Non, 1 millimètre, on n'arrivera pas. OK. So now we're going to rim here. And I like to rim. I'm going to put a 29, but I'm going to rim at 25. La gauche, s'il vous plaît. This is an osteophyte. In fact, when you remove the osteophyte, you're at the good position. Okay. Okay. Okay, le rimel. Qu'est-ce que ça veut dire? La gouge. On sera en 29. Ok, on va élargir le plot central. Okay. So we're going to make some hole here for the glenoid, for the graft, sorry. Okay. And now we're going to prepare our graft in order to put it perfectly. I want to compensate this c'est ce qu'il y a?
Ok, on a une paire de gants. C'est la colonne. D'accord.
Annulé. Annulé. Fermé. Fermé. Quitter. On a la râpe?
Allez, ici.
Annulé. Annulé. So I'm going to take my graft here. You see the graft? And what I want is to adapt a bit my graft here. So I'm going to remove some bone inferiorly. Okay? Here? You want to see the graft again? So I'm going to adapt my graft. So if you want, you can put your graft like this and check if everything is okay. I think it's okay. You agree, Philippe? Look. Okay? Okay, like this, perhaps a bit more. like this, and maillet. So when it exists, it's possible. You need to enlarge a bit the hole. This is a long peg, yes. When you use a graft, you always need to use a long peg. You see? I think it's correct. Huh? You can see very well the graft. You see it? Yes, very good primary stability, primary fixation. I just want to put it a bit more. Okay. So now if you remove that, you can see that the goal is a shift. You have bone here. Posteriorly, you have almost no bone here. Look at here. You have the big graft superior because we wanted to compensate a huge inclination, as you can see here. Okay for you, Philippe?
Fantastic. Perfect.
Okay. The goal is that. So now, if I want, I can have a look. Focus.
Ah,
blueprint.
A blueprint.
c'est hashtag là. C'est le hashtag là.
No, normally it works better, but
Où est-ce que c'est le hashtag?
là, s'il y a une caméra extérieure, je vais passer vraiment pour un âne. Hop, 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 hop.
Avec le poignet, monsieur Collin.
Allez, on redémarre de là. If you have this, you just need, je fais le blueprint, hein.
Oui, tout à fait.
Tac. When you have this, you just go to on your wrist. Okay, perfect. So you see now, what you can do here is to check with this. You can check here, not this.
Hein?
Here.
C'est pas le hashtag?
You see the sphere? So I can unlock it and modify it and to check if it was what I have planned. Here. Like this. OK? OK. Allez, on va visser. So I always start by the superior screw here.
Allez-y. Ça, c'est pas pratique, ce truc-là. Hein, non?
Une 45. Deux 45. I'm going to put it manually because she's an old lady. I don't want to break everything. So I suggest to you to start by the inferior screw. Why? Because if the bone is a bit soft, then you can have some inclination like that of your implant. And it's always better to have a bit too much inclination than a superior inclination. Inferior inclination is always, always, always better. So you need to be very, very gentle here. OK, à la main. We can finish here.
Screw?
Not no, for the inferior and the superior, it's not a locking screw because I want to have some compression in my graft.
Okay.
So you can see here, I'm very happy because you look at the graft. You can see that the graft is bleeding. I love that. Look, you see that you can see the graft is good. See here, same. So now, like that, I have one superior and one inferior, and I love that. So now the anterior one and the posterior one are locking screw. 32.
Ils reçoivent mieux, là?
2,32, s'il vous plaît. So here, so you can unlock it if you want, position it differently. Here, if I want to see my graft, I can go there and see only everything that I want. OK, 32.
32, tout à fait. 2, c'est 32.
OK. Merci. So I encourage you to be very, very cautious on the anterior screw and shouldn't be careful to not, because you can break everything. Okay. Really, you can finish everything like this. And now it's a locking screw. You can see.
36 ou 39?
36, s'il vous plaît. Okay. And you can see very well everything now. The graft. Quittez.
Je le prends avec la pince.
Quittez. Annulez. OK. De quoi laver? No, because, you know, that's a very, very interesting question, Philippe. I think that we should always keep in mind the best for the long-term follow-up and the best for the short-term follow-up for the patient. I think that this patient, she's more than 80, and the problem for her is not the notch. The problem for her is to be able to use her shoulder as soon as possible. So I don't want to elongate too much the deltoid and don't want to have too much tension on the deltoid, just what we need in order to have a very quick rehabilitation, because this is the most important point for her, I think. So this is the glenoid, the sphere. If you have any problem, you can check here. Tack. Here. Ah, that's what I wanted to see previously. So we've got this, okay? And now we're going to put it here. So at this step, you need to take the retractor by yourself. You put your sphere like this, and you retract a bit. But yeah. So this, with this device, you need to check that it should be, you need to hear something. You can see, up, that's good. So normally it's finished. What you can do is to look with your sphere now. Okay. Okay. So now what you do, you are going to make some trials here, like this. Au Mans, x3, s'il vous plaît. Et la tarte, merci. Un troisième moment en haut. Merci. Alors, de quoi retirer le protecteur? OK.
Qu'est-ce qu'il dit là? Êtes-vous capable d'imposer le plan?
OK. Le plateau. Donc, this is the tray. You can see it. So it's a low eccentricity, and we are going to put it in this position. Like this, I'm going to distalize a bit. So in order to answer to the question of Philippe, when you put your tray like this, it's not like an eccentric sphere, but you distalize a bit more the humerus. If you put it on the other way, with this higher, then you lateralize more.
What do you want to do for this patient?
I think it's probably a bit useful to distalize a bit. It's always better. Okay, so we're going to make the trial. Okay, this is done. So I can check the range of motion that I have. External rotation, internal rotation in position 2, not so much. And you can check here, joint, range of motion, I think it's here. Huh? And you can check, look, you can check what I've pre-planned and what I can have now.
Ouais, c'est ce que j'ai cru comprendre.
Is it clear for you? We can do it again if you prefer. Okay. You want to do it again?
What?
So replay full range of motion. Look, this is what we have planned. Here, 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 internal rotation, external rotation, and this. Okay, so now we're going to put the definitive, the last implant. Non, le chausse-pied, s'il vous plaît.
Do you check the possibility to repair the subscapularis before?
I will at the end, in fact. Here, it's going to be a bit difficult, but we'll see.
Because
I think it's going to be a bit difficult to reattach the subcap. We can check now if you want, Philippe. Huh?
Yes, I think
check. Okay, far above, s'il vous plaît.
It's better because
yeah, we don't need to make hole.
Maybe you can do a medalization of the humerus to repair easy.
I think it's going to be possible. Look at it.
Okay.
Look at this. I think it's okay. Huh?
Okay. No problem.
So we're going to reattach the subscap. Okay. Les trois au Mans, s'il vous plaît.
C'est la tige? Oui. C'est une tige courte? Oui. The inclination of humerus is 145 degrees?
Yes, the final one, yes. Quittez. The cut is around 132, and you compensate in the poly. Quittez.
145.
At the end, it's 145. So I'm going to make the hole to put thread in order to reattach the deltoid, the subscapularis, sorry. Allez, la mèche, s'il vous plaît. Merci, Alex. One. 2. Oops. 3. OK. Le fil.
C'est bon?
On se relâche pas. Hein.
C'est parti de la conversation, très bon cas.
Allez, hops.
Des questions, hein?
So I really take advantage of this time because we have nothing to explain here. To thanks again everybody from Striker, Isabelle, Maya, and I'm sorry, and Charles. Thank you so much because they've worked a lot previously to prepare everything. They send email on Sunday. They work a lot, and I would really like to thank them. They're really engaged in what they do. Okay, so now you see that it will be a transosseous suture, as you can see here. I've made a plan here, a mark, in order to keep my 20 degrees of retroversion. And we're going to put the final implant. Changez de gant, s'il vous plaît. Quittez. Annulez. When I say quitter, annuler, in fact, you have this. And then you can do, if you want to take picture, you can take picture. If you want to record, you can record. But sometimes you need to, we don't need of it. So you say annuler or quitter with fermer, fermer. And you see, it's closed. I would like to have that in the daily life. You just say something and it happens, but unfortunately, it doesn't work like that. Ah ouais, putain. Annulé. Wonderful. Allez. Let's be serious. It's surgery. Okay. This is okay. We check.
C'est une tige en 2B, c'est un plateau en 0, petite excentration, et la tige de rétroversion, elle est sur 20 degrés.
Merci, Alex. So here, I have my landmark. Maillet, s'il vous plaît. Merci. And done. I fixed I call that the twist test. You see, you have a very good primary fixation. That's good. Now we're going to put the tray, the pulley, sorry. This is the tray. 36 plus 6. Plus 6 means the minimal one. Okay. Maillet. Okay. Like this. Then you just need to let go. I like the song. Okay. So now we are going to reattach the subscap. Parabuff, s'il vous plaît. Parce que dans cette boîte, je crois qu'il n'y a pas de Richardson. OK.
Les lunettes, on peut les utiliser simplement avec Wright, hein, c'est ça, hein?
OK.
Il y a un qui a des cheveux.
Il y a quoi?
Des fils.
Ouais, j'ai vu.
Oui.
OK. Like this. Tiens, prends le bras comme ça, s'il te plaît. So we have the superior thread here. This is the superior thread. The medial one, the inferior one here. And here. Of course, I totally forgot to thank. This is very, very important. In fact, I didn't forget. I wanted to do it at the end. All the team in Brest, the IMASCAP team, I will not say this person or this person because it's really a team. It's a wonderful team. And amazing team. They did this, and it's a wonderful software. So I would thank you so much for all what you do every day. And I can say that we are going to have, I think, as soon as possible, the guidance. This is only the first step. The guidance will be something very revolutionary. No need of PSI anymore. Just need to, if you want to create a PSI, you can do it 5 minutes before surgery. It's going to be very, very different in our daily practice. So, be careful. Okay. And the last one, the superior one is here. Faites attention, Charles, vous avez pris le... Ok, attention. Voilà. So, I don't know if they're online or not, but if they're online, a big hug to all the team, IMASCAP team in Brest. And the head of the department is Jean Chaoui, and they are all incredible. So I'm going to stop to thank everybody because you are not in the United States. Okay. Ok, coupé. Coupé.
What is your post-operative mobilization?
So if I reattach the subcap like this, I will put a sling in internal rotation for 3 weeks. But we start quitter, fermer. But I start rehabilitation immediately with a protocol that we have established with the physio. Okay. So you see that it's very useful to put a thread in the pec major at the beginning, because most of the time you forget to reattach it, but I'm going to reattach it now. No, not too much, not too much. Oh, be careful. So now we're going to wash. Ciseaux. C'est pas ces ciseaux-là, c'est des ciseaux de maillot. Okay, can we wash? Okay, section. So I think it's finished. Thank you, Alex. As usual, you've been wonderful. Thank you, everybody, all the team. You can close? Thank you so much.
Everyone, thank you for all the attendees. You know that the surgery was very simple. And Philippe did a good demonstration of IMASCAP preoperative planification on the material, and he did a bioassay. And you see that he restored lateral offset because it was very easy to repair the subscapularis. And now in postoperative, we do a passive range of motion. We avoid to do external rotation during 3 weeks, but we do passive anterior elevation. So thank you to follow this live surgery. You can see it in replay with Hélène Dallet. We will do that in replay next week. I wish you an excellent summer. And the next appointment will be the shoulder board in 7 September. And I invite some experts to manage the glenoid loosening, tips and tricks, and to simplify this difficult situation. I would like to thank Wright. I would like to thank all the team of Wright in ASCAP, the fellow here, and Bizet, who accept to do this type of event. So do you remember that 9 July, we have a free Congress. This is Global Shoulder Arthroplasty around the world. It is free. You can connect during 24 hours and you can follow all the shoulder and elbow society of the world. We start with Australia and we finish with New Zealand. Thank you for all the moderators and all the speakers for the event. I wish you a very nice evening. Bye-bye.